I want to thank Rajshekar Verma and Dr. Anil for this opportunity. And my case is a 74-year-old male with long-standing diabetes, hypertension, admitted with acute pulmonary edema. He was in the ICU. He was in congestive heart failure. Lab showed normal renal parameters, an NT-proBNP of in the range of 20,000. Chest X-ray was sensitive acute pulmonary edema. He was treated with Lasix infusion and inotropes. This was ECG at presentation, a poor R-wave progression all the way from V1 to V5, and a nearly normal axis. This was his echo at presentation, severe LV dysfunction, distal IVS was thinned out, hypokinetic, and he had no mitral regurgitation, but although very severe LV dysfunction. You can see in the four-chamber view, although the pictures are not very clear. This is supposed to echo. We did a cardiac MRI to look at viability, and it showed severe LV dysfunction, and majority of segments are viable except the distal LAD territory. This was a late enhancement showing a transmural scar in the apex and a subendocardial scar in the lateral wall, suggesting, if you look at the MRI report, 4 out of 7 LAD territories were viable, 3 out of 5 in circumflex was viable, and 4 out of 5 in RCA territories were viable. EF was 16%. This is an angiogram, total occlusion of the LAD after a major diagonal. Diagonal had disease 2, circumflex had 2 critical stenosis, all calcified stenosis. This is the PA cranial view showing the total occlusion of the LAD. And this is RCA, again 2 critical stenosis in the proximal RCA and the precrux RCA. So this is a summary of the angiogram, total triple vessel disease, severe calcified coronaries, total occlusion LAD, diagonal, circumflex, and RCA. So every Saturday we have a heart team meet, we discuss surgeons, and he was considered very high risk for surgery, and he was planned for protected PCA with Impella support. Why Impella? I'll tell you why. This is a slide which has been played all over again multiple times. Multiple considerations goes into when you decide on a mechanical circulatory support, the patient criteria, whether the patient was with heart failure, severe dysfunction, long-standing diabetes, and also the vessel angiographic considerations, the complexity of the lesion, calcification, left main, and also the hemodynamic compromise, whether he had severe LV dysfunction at presentation. This is another tool which helps you in determining whether you require mechanical circulatory support. If you look at the EF is less than 20%, then there's a simple or complex PCI, you definitely require MCS. If it's the EF is between 20 and 35%, if it's a complex PCI, the high syntax score, you require Impella. If it's a simple PCI, and you can do it without Impella, and if it's the EF is more than 35%, it's a complex PCI, definitely require a support, and a simple PCI, no support. This is another tool which helps you determining what support and what is required for this patient. Again, other considerations, you should ask yourself, is the patient hemodynamically unstable? Does the patient lack the reserve to sustain a brief ischemic insult? Is the patient risk for complete interruption of blood supply that lead to hemodynamic collapse? And is the patient at risk for prolonged ischemia during the procedure? And all of us know protected PCI improves quality of life, improves ejection fraction, lowers the rate of acute kidney injury and need for dialysis, reduces the length of hospital stay. So how do you decide whether you need ECMO or you need Impella? If you look at high-risk PCI, the majority of vascular complications are more with the IABP, less with the Impella. Major bleeding complications, again, more with the IABP, less with the Impella, and stroke also rates are slightly more in the IABP arm. If you look at cardiogenic shock substrate, again, if you use a VECMO, the bleeding rates, the vascular complications, stroke, significantly higher than the Impella. So this is the Impella. People who are not familiar with Impella, we have different gradations of Impella, 2.5, CP assist 5, and 5.5. 2.5 means it increases the cardiac output by 2.5 liters per minute, and the CP gives a increased cardiac output by 3.5 to 4, and Impella 5 up to 5 liters of increase in the cardiac output. So this is how description of an impeller. You have an inflow valve which is placed in the ventricle. It actually sucks blood from the ventricle and delivers it through the valve into the aorta. So by sucking blood from the ventricle, it reduces end-diastolic volume, reduces end-diastolic pressures. By delivering blood in the aorta, increases the aortic pressure, and increases the flow in the coronary circulation. This is how impeller helps in hemodynamic support, increasing flow, increasing mean arterial pressure, reducing LV end-diastolic pressure and end-diastolic volume. So by reducing end-diastolic volume, reduces wall tension, reduces microvascular resistance, improves coronary perfusion, improves oxygen supply, reduces oxygen demand, also has a cardioprotective signaling, reduces reperfusion injury. This is an example of a patient who had an impeller. This is a sublingual microcirculation before impeller. You can see the circulation does not fill up at all. With the impeller on, you can see the microcirculation filling up. Again, example of a patient who had a occlusion of the circumflex, and there was when your gamma technetium scan was done, it showed no perfusion in the circumflex territory. When the patient was put on impeller, there was improved flow in that particular territory. So having an impeller improves the coronary flow velocity, and at least in this patient, from 61 to 72 centimeters per second. This is an impeller, the automatic impeller control arm. This controls everything. We have a purge catheter. If you have a monitor here, you can. This is the purge system. This is the impeller interface. This is the catheter. And this important thing is to purge continuously, otherwise the motor can get clogged. And what we use as purging is a 5% dextrose saline with heparin 50 units per ml. This is delivered continuously through the purge catheter. This is an automated impeller controller which controls everything. There's a display which shows the placement screen, the home screen, infusion history screen, as well as a purge screen. The impeller 3.5 increases, this is showing the 3.5 liters per minute of increased cardiac output. Then you can see the battery status here. This is the cart which you can carry this impeller around. If you have a patient who's an emergent patient who requires transportation of the impeller to another unit, you can take this in this cart. So coming back to a patient, the patient was well diuresed. As a result, end-diastolic pressure was only 12 millimeters of mercury. This is the PA pressure was 28, 16, and 11. End-diastolic pressure was 12, and the LV pressures were 85, 31. When we started this case, the patient's RA mean was around 2 to 3 millimeters of mercury. He was apparently well diuresed. As a result, RA mean was low. So when you have an impeller on, before putting an impeller, you have to ensure that the RA mean, you would increase give fluids so that the RA mean improves. Otherwise, the impeller would not probably work. So we gave a lot of fluids, increased the RA mean to 8 millimeters of mercury, and then started this impeller. So how was the impeller placed? Left femoral ultrasound guided access, 2 perclose catheter sutures placed. Then we have a 13 French P-level sheath, and through this we place this impeller in the left ventricle. So this is the after placement impeller. This is an angiogram, again showing the LAD total occlusion, and as well as the lesion, the diagonal and the circumflex. So we needed 2 calcium because when you looked at the angiogram, there was extensive calcification. So we needed to have a calcium modifying techniques available, both the rotablator and the IVL at present during the procedure. So the patient we had difficulty crossing into the LAD. We used ultralumen microcatheter, which is placed, the crusade catheter is placed in the diagonal, and then we wired the LAD. So it took some time before we could wire the LAD. And then after wiring the LED, we used a 2.5 NC balloon. And you can see the waste in the balloon. There's a lot of calcium. So we used a 1.5 millimeter rotabur to increase to facilitate passage of the shockwave balloon, 312 shockwave balloon, 30 pulses delivered. And then we placed a stent in the diagonal before we placed a stent in the LED. And then we had a good result in the diagonal as well as the LED. Then coming back to the circumflex, the wire would go in easily, but none of the balloons. We used a 0.8 size AVO or a Nick Nano balloon. None of the balloons would go inside. We tried for some time, then we thought we should come back to the RCA and come back to the LED. There's some problem with the guiding support. So we did the RCA again first with the 2.5 NC balloon. The patient had stable hemodynamics all throughout the procedure, thanks to the impeller. And then we had to use a rotablation in the RCA. Again, shockwave balloon was delivered, multiple pulses delivered in the RCA. And then we finally placed two stents, Zynes 3.5 in a 48 in the distal RCA, and a 3 in a 48 stent in the proximal RCA. We came back to the, sorry, I'll just take 2 minutes more. We came back to the circumflex again. We changed the guide this time. We used a AL2 guide, and then we used a telescope guide extension catheter, deliver the balloon and the rotablator as well as the shockwave balloon. So we used approximately 5 shockwave balloons. 2 balloons ruptured during the procedure. And so this was the outcome after stenting the RCA circumflex with 2.518 and a 3 in 33 Zynes alpine stents. The patient was kept on the Impella overnight. Next day morning, we weaned him off the Impella, and the patient had stable hemodynamics. Just before weaning, this was the blood pressure and the hemodynamics. Further course, patient had an uneventful course. 3 days later, he had a AICD implantation done, and 4 months post-PCI, he's doing well. He came for a follow-up yesterday. LV function is improved. He's in good function class 2. And this is a slide showing the EF improvement in multiple registries. I want to conclude by saying that patient is stable in a patient who had severe LV dysfunction during complex PCI, which required multiple calcium-modifying techniques. Having an Impella helped in stabilizing the patient during the procedure. The first use of Impella in any setting in the state of Kerala. I was slightly dampened by this trial which came out in this ESC revived BCS2 trial. We showed that in 300 patients were randomized into the PCI arm in patients who had severe LV dysfunction. Other arm was patient kept in optimal medical management. And they found at 1 year, there was no improvement in ejection fraction, and there was no improvement in outcomes as far as death and other things were concerned. So are we really doing a good thing by revascularizing a patient with multivessel PCI is the question which needs to be answered. Waiting for the outcome of the PROTECT 4 trial to give a final answer to this conundrum. Thank you very much.
Thank you, sir, for the excellent demonstration. I definitely feel it was such a long case, and all the procedures in one sittings would not have been possible without Impella or mechanical support. I really appreciate it. Thank you.
Yeah, in fact, there was a small paper that was published in JAC, I think, from some centers in the US, which showed that if you put MCS and the only subset of patients who do benefit from MCS are the patients who undergo a functionally complete revascularization. The ones who fail complete revascularization, irrespective of the fact that you have put an Impella or any other support device, they do not do too well. So in this case, probably that is the message. If you're putting MCS, please ensure a functionally complete revascularization.